Hi everyone, it's really great to have you all here with us for our Pallaborative Education Special today. For those that don't know me, I'm Claire Robinson. I'm the new Registrar Coordinator for Pallaborative, working alongside Tom Steele, who sadly can't join us today. It's my absolute pleasure to have our guest speakers here today, Joe Cliff and Anthony Thompson. Next slide. So a run through of today, so a welcome to you all. I'll be going over our audit and guideline development programme for 2021 and 2022. We'll then move on to our few presentations of the day. We'll have questions after each and then any further questions at the end. Next slide. So in terms of current guideline development groups and audit progress today, we're just awaiting an update from anticonvulsants, but I believe they're ready to send their survey out. So if we can be kind of thinking about any cases that we might have to enter in the foreseeable future, that would be helpful. I think ketamine are just sending out their survey at the moment. So again, think about patients that we've had using ketamine that we can enter. And again, if you have the ability to enter 10 cases, then you'll get a localised report. Next slide. We'll then in January have an education meeting with Dr. Alison Copley and myself. We'll then be moving on to renal failure in March, who are undergoing their literature review at present. We'll then have an education special in May. We'll move on to interventional pain techniques in July. They've had a couple of meetings and are ongoing with their literature searches. And then breakthrough pain in September, who have had their first meeting and again are in the progress of literature searches. And then a quality improvement showcase in November to look forward to. So I hope you can put those in your diary and look forward to those. Next slide. Okay, so without further ado, we'll move on to Dr. Joe Cliff, who's a consultant in medical oncology, whose title is Advances in Oncology, Step Changes and Challenges. Next slide. Moving on to Joe.
Can you hear me now?
Have we got Joe's presentation up?
Right, apologies. Hopefully you can see the first slide now. So I'll make a start. So thank you for introducing me. I'm Joe Cliff. I'm a consultant in medical oncology. I'm based at the Clatterbridge Cancer Centre in Liverpool, but usually I'm to be found in clinic in Halton as I look after systemic treatment for breast cancer patients within the Warrington and Halton service. Alison asked me to give an update in oncology, which I immediately agreed to and then came away thinking, well, what am I going to talk about? I've chosen 3 areas to focus on, and I've chosen these because they stand out to me as areas that have really made significant progress. And in fact, even in the time that I've been a consultant for the first few years, they've changed entirely since I was a registrar. And when I go and do my acute oncology practice at Warrington, there are a couple of the areas that really make me think, because things have changed so much in these areas. And in fact, sometimes when people I'm told what drugs people are on, I kind of nod and smile and then quickly run away and go and look them up. So what am I talking about when I think about step changes? We know that we often see a lot of incremental benefits in oncology, and as oncologists, we can spend an awful lot of time looking at these survival curves. This just happens to be looking at 2 drugs instead of 1 for advanced pancreatic cancer. There is a little bit of a gap there, and people study these and decide whether they're statistically significant or they're certainly statistically significant, or whether they actually give clinically meaningful benefit, and analyse for ages whether you can target your treatments without causing too much in the way of side effects. But I appreciate that these aren't terribly interesting to anyone outside of medical oncology, and to be honest, even to us sometimes it gets a bit frustrating. What is always nice is when we can see, she says, let's move the slides on. It's always nice when you get a trial that comes along that you can actually see clear daylight between the survival curves. And it's always exciting to see something that immediately you know is going to change practice. And it's always nice as well when you see the top survival curve, including something which is less toxic than the one that doesn't do so well. You feel that actually this is something that's going to change practice, is going to move cancer care on, and hopefully do so not at the expense of quality of life for patients. I've just chosen an example here, and this is something we'll talk about later. So as I say, I've defined a step change as something that I barely recognise since being a registrar, that things have moved on so much just within the last several years. And I'm going to talk about some of the challenges associated with this. I've stepped out of my comfort zone, so I'm talking about metastatic malignant melanoma and advanced non-small cell lung cancer first, and then, to be slightly kind to myself, I will step back into an area that I feel far more comfortable talking about, and just give you a quick update in metastatic breast cancer. So metastatic malignant melanoma, it affects often quite young patients, and fortunately most people present with very early disease who don't have any further problems after their surgical resection, but about 1 in 10 patients does present with late disease. For many years, the standard treatment was to offer dacarbazine chemotherapy. Response rates were a dizzy 20%. The only good thing about this drug is, actually, compared with a lot of cytotoxic chemotherapy drugs, it was actually fairly well tolerated. But the median survival was around 6 months. Even during this time, though, it was known that there was something about melanoma that responded to the immune system. Interleukin-2 is a drug that can really activate the T cells of the immune system against cancer. People knew that there was something about melanoma that could respond to our natural immune system. Some people did receive this, but they had to be incredibly fit and well. They had to have absolutely normal organ function. And sometimes people actually, for a cancer that actually had a median survival of 6 months, could achieve long-term disease control. However, it was pretty sporting. You had to have nerves of steel and an ITU bed available, as the side effects included pulmonary edema, renal failure, to name but many potential side effects, and listed in those was death. So this isn't a treatment that you could really apply to many people. This looks like a very complicated picture, but what people started to realise is that we can potentially use the immune system in slightly better, slightly more controlled ways that don't cause such drastic side effects for so many people that you give them to. What this picture shows is you've got your T cells, the spiky round things in the middle, that can recognise cancer cells, and actually, given the release to do so, can attack cancer cells. But there's also checks and balances in the immune system, and the purple, blue and turquoise bits are some of those that, when they're all bound together, actually kind of slow the immune system down. They have a purpose. They stop our immune system fighting its own self and can reduce the risk of things like autoimmune diseases. But people realised, actually, if we could target some of these with drugs, we could take the brakes off the immune system and allow our T cells to fight tumour cells. And in a cancer like melanoma, which we know could respond to the immune system, that was a natural place to start. So in metastatic malignant melanoma, one of the first trials that really changed practice was this one. I don't think anyone really knows what GP100 is. Someone must do, but in my view, it's basically placebo. The details of this survival curve aren't too important. I appreciate it's all a bit fiddly and not so easy to see. But you'll see that by giving the ipilimumab, which is the CTLA4 inhibitor, that brake on the immune system that is released by giving the ipilimumab, there was a survival advantage. What was particularly interesting is this, the tail of the curve. It didn't suddenly make survival an awful lot better. As you can see, the curves drop off. Still, a lot of people, unfortunately, were dying of disease within 12 months, and certainly by 24 months, many people, unfortunately, had succumbed to their melanoma. But what was interesting is, in patients that received ipilimumab, it didn't drop, the survival didn't drop to 0. And the graph goes out to 4.5 years, with 10 to 20% of people still alive. So this raised eyebrows and was the first inkling that actually this was something that we could potentially tap into to really make a difference for these patients. This is another example of checks and balances on the immune system with something called the PD-L1 inhibitor. So the PD-L1 complex that you can see between the T cell and this tumour cell is providing the brakes to stop the immune system going crazy and fighting self, basically. But it has the ability to, and anti-PD-L1 drugs can take that brake off and allow the tumour cells, the T cells, sorry, to fight the tumour cells. And a new breed of immunotherapy drugs were born. One of the most common is this drug called nivolumab. Being oncologists, we find a drug that works, and then we see if we can put it together with other drugs to make it work even better. The green line is what happens if you give the 2 types of immunotherapy drug together in melanoma patients. What we can see from this is the response rates. The people who got the really long, durable responses are a far higher proportion with the 2 drugs together. And out at 5 years, 52% of people were still alive, some still with evidence of disease on their scan from looking at the bottom graph, but were alive. And from a cancer that just a few years ago had a median survival of 6 months. This is why I've called this a step change. I think it's a huge leap. And in fact, the most up-to-date sort of update on this trial was presented not long ago, with the median survival somewhere around 6.5 years. So obviously that's a really good thing. Actually, immunotherapy is tolerated really well by many patients. But of course, it does bring challenges. We've now developed a whole new sort of side effect to anti-cancer treatment. As oncologists, I hope we were reasonably good at managing chemotherapy-related side effects and knowing how to modify treatment and weigh up the pros and cons of treatment to try and help improve survival in those with metastatic cancer without too much of a severe impact on quality of life. These bring a whole new lot of side effects. Chemotherapy side effects are completely different. These people on immunotherapy often feel very well on a day-to-day basis, but because we put the immune system into overdrive, are at risk of developing immune side effects because the immune system does indeed start attacking your own cells. And the most common things we see now are colitis, hepatitis. Again, patients very well, but on blood tests, we see AST and ALT rises in the hundreds, which we have to manage. The patient often doesn't know why we're quite so worried because they feel fine. Similarly, with the nephritis, we can see renal failure with very, very fit and well patients. And it's changed. We've had to kind of completely educate ourselves again to be able to manage things. Now we get a melanoma patient up on the clinical decision unit upstairs presenting with headache. And now it used to be that we'd be thinking, let's do an MRI for brain metastases. Now our first thought is this hypophysitis? Have they got inflammation of their pituitary gland? And we're checking all their hormone levels because, you know, cortisol, thyroid function, testosterone in men can all form. So we're really having to broaden our skills and involve a lot of other medical specialties to get on board to help us out when we're having to use drugs like immunosuppressive drugs like tacrolimus and MMF to try and dampen down those with the most severe immune mediated side effects. So this has caused a need to expand our staffing, and we now have a whole immunotoxicity team to try and manage the challenges that this brings. What's been a real eye-opener to me is we don't even really expect fatigue with immunotherapy drugs. So a patient on immunotherapy who complains of sudden tiredness, rather than blaming the drug, we start it per se, we're then checking cortisol levels, and indeed it can be a symptom of myocarditis. So it's been a very rapid learning curve. I think from acute oncology point of view, and I suspect also from a palliative care point of view, there's been a real shift in expectations around prognosis. So as you can see from those curves, it's very difficult to know at the beginning how well a patient's going to do. Are they unfortunately going to be one of those people who just don't respond? Or could they be one of those people who actually achieves really long-term survival? And I guess my reflection on this is, as an someone who goes and does acute oncology and is asked about escalation of care, if I see someone now who is 2 years post starting their immunotherapy and they're well and stable on treatment, you know, if you're asked, should this person be for ITU admission? Well, gosh, yeah, probably, because actually our expectations of survival are incredibly different. And talking to the melanoma consultants, when they're asked about prognosis at the beginning, they have to give a very broad answer. And it's only really after a patient's been on treatment for 3 to 6 months that they can start to get a feel for which way things are going to go. Obviously, we still don't know about long-term outcomes. Data's not mature enough. We've got to that 6.5-year point, but are we still going to see recurrences then at 10 years, 20 years? That's still uncertain. And that brings psychological burden to even patients who are doing really well. And it's raised this concern about steroids. We know that steroids can dampen immune responses down, and I think that's caused a little bit of anxiety about people who come into contact with patients on immunotherapy. The general feel is that the most important bit, the most important time to avoid steroids is during the first cycle of an immunotherapy treatment. It seems to be then that the immune system is really teed up and primed to fight the tumour. And if you give steroids, particularly at high doses within that first cycle, there's a real concern that there could be a dampening down of that response. After that first cycle, however, the general advice is if you really feel that someone needs steroids for symptoms, whether it be they've got brain metastases, whether it's nausea or other complications that we use steroids for, that actually, if there's a clear indication, it is okay to give it. They do need to be down to an equivalent of 2 milligrams of Dex or 10 milligrams of prednisolone by the time they receive their next dose. But, you know, there may be a clear clinical indication for why, you know, deferral is necessary. I'm now going to make a huge leap, having talked about that huge leap, and just talk for a few minutes about non-small cell lung cancer. So when I trained, and I don't consider myself having been a consultant for that long, just a few years, and I lasted non-small cell lung cancer working for Dr. Marshall just a year or so before I finished. Generally, we were treating all patients with carboplatin and another chemotherapy drug. It didn't really matter which you chose, but the response rates were about 30%, median survival about 9 to 10 months. And the challenge was always to pick your patient, pick the people who are most likely to benefit, spare those the toxicity who were unlikely to gain benefit. And that was the real skill of the lung oncologists. It was then noticed that clinically there was a small group of patients, particularly with adenocarcinoma of the lung, that were characterised clinically by being more likely to be female, non-smokers, there's obviously not a typical non-small cell lung cancer patient, but we know that a lot of people who develop non-small cell lung cancer are smokers and perhaps have COPD and other comorbidities that go along with that. Not all by any means, but it's more common in this patient group. But this group of female non-smoking patients stood out as being quite different. It was realised that actually they appeared to have a better prognosis from their non-small cell lung cancer. And this was associated with an EGFR mutation. What's that? That I put in as a bit of a joke. I'm not going to talk too much about this, but this is the kind of mess that's going on within our cells, all these different chemical pathways that are all working interlinked to control the growth of cancer cell, of a cell, and can go badly wrong within a cancer cell. The EGFR mutation relates to this receptor, as I always explain to patients, like a docking port that sits on the outside of the cancer cells. And growth chemicals can bind on, and when they do, it changes the shape of the receptor and sets off a stream of chemical reactions and changes in the molecules in our cells, which can send messages to allow the cell to continue growth at an increased rate, to proliferate, to increase the chances of survival. So if you've got a mutation that affects something like the EGFR the EGFR molecule, it can basically be set permanently to the on switch. We don't need the chemical to activate it anymore. It's just permanently driving the growth. That then gives you a target to try and treat, rather than giving chemotherapy, which isn't targeted really at all, other than the fact that it preferentially damages fast-growing cells. And in lung cancer, there's been an expansion of recognition of different groups of people who have mutations like this that basically act like a switch. And if you can turn that switch off, you can produce responses in the cancer and change the prognosis for people. And that's with avoiding chemotherapy. So there are now a group of people who don't need to come near a chemotherapy drug, certainly in the initial management of their metastatic lung cancer. And rather than just lung cancer, platinum chemotherapy, which is what I had to learn essentially, we now have these complex pathways, which all patients now have this panel of whether they've got one of these driving mutations, and then increasingly we can treat that mutation. Now, still, this is a smaller group of patients. About 15%, adenocarcinoma is about 40% of non-small cell lung cancer. There's EGFR mutations in about 15% of those. Just a few percent will have an ALK mutation, and 1 or 2% will have a ROS1 mutation. So still, the majority of people with non-small cell lung cancer need to go down this other arm of the pathway that now, again, immunotherapy has come in and played a role. Lung cancer isn't quite so sensitive to the immune response as melanoma is, so they do look to see whether there's enrichment in the cancer of this PD-L1 thing, which you may remember was one of those blue and purple kind of breaks on the immune system, to see if you're more likely to get a response. And in those that have got a lot of that, again, you can probably avoid chemotherapy and first-line treatment. In squamous cell carcinoma, it's a slightly less complex pattern in terms of treatment decision. And this just gives an example. I'm not going to go through the results for all treatments because I think I'd bore you silly. And to be honest, the key thing is that there are now a group of non-small cell lung patients who we don't offer chemotherapy. There are other options there that in general are better tolerated. I think there still has to be an awareness that although these drugs are better tolerated than chemotherapy, we've talked about immunotherapy, which is like a pembrolizumab, but even these targeted drugs, yes, they're better tolerated, but many papers will say, well, you know, there's not a lot of severe toxicity. I think we still need to be mindful that even grade 1 or 2 diarrhea, for instance, actually has a huge impact on someone, and most people wouldn't want to leave the house with that. So I think there's still quality of life issues there. In terms of survival, going from what I initially talked about with carboplatin type regimes of a median survival of around 9 months, we're now looking for people who are suitable for these sorts of treatments at perhaps more pushing up to a couple of years, and with some of the targeted drugs maybe up to around 3 years on average. A lot of these trials are done in fit and well patients though, so there is still a really big group of patients who have got coexisting COPD, poor performance status and frailty, in whom even though there are less toxic treatments available, actually still the right treatment is good supportive care. The challenge is it's very confusing for non-oncologists because this has grown hugely. I've kept those kind of algorithms fairly simple. But what I've learned in writing this talk is that they're even getting down to the point that it's not just the gene mutation, but actually the specific gene mutation that they're targeting treatment at. You know, if you've got an exon 20 mutation, you might have this drug, and if it's a non-exon 20 mutation, you might have that drug. So in lung cancer, there's been a real move to this kind of holy grail of personalized medicine that's kind of come out of nowhere and is mushrooming. I think it's more difficult for patients at diagnosis. Now there is a little bit of a wait to start treatment because, as you can see, it's not a one-size-fits-all approach anymore. You have to wait for all of this analysis to take place to know what the right treatment is. And I think there is sometimes a tendency now for lung physicians to be kind of pushing for biopsies in less fit patients because they feel that perhaps there is a chance that they'd be suitable for one of these targeted drugs. And I think this is something that I'm conscious of from an acute oncology point of view, that still, if you've got someone who's frail, performance status 3, still the right thing is avoidance of invasive procedures and best supportive care. But I think that there is a shift in expectations now. I'm really sorry. I hope I'm doing all right for time. I can talk for Britain and I have to rein it in. I will give a very quick update for metastatic breast cancer. We've known for ages that this isn't one disease. It's sort of 3 main groups of disease: triple negative, estrogen sensitive, and HER2 positive. Triple negative, there's been little change. Immunotherapy really hasn't had an impact in breast cancer management. It doesn't seem sensitive to it. There's a very small group of triple negative patients who are PD-L1 positive who benefit, but this is a very small minority of the patients we see. So largely we rely still on chemotherapy, and there's been very little advance. In estrogen sensitive breast cancer, which is some of the most satisfying bits of work that I do, I think, we know that we can sometimes achieve really good disease control with anti-estrogen therapies, which, touch wood, for many weak people actually fit into life without causing too much impact on their ability to continue to work should they want to go on holiday, continue many activities of normal life. We are now giving targeted agents alongside this, though. We know that with metastatic breast cancer, eventually cancers will become resistant to the fact that we're starving it of estrogen and will learn to grow via different pathways. The CDK4/6 inhibitors like palbociclib, abemaciclib, ribociclib all block that escape pathway with the aim of trying to make the responses more durable. And although the side effects, when you look down the list, look a bit like chemotherapy, actually the incidence of those side effects and the severity are much less. So there is a very small risk of neutropenic fever with these drugs, but it's around 1% as opposed to over 10% with many chemotherapy regimes. So we advise people to check their temperature, but the risk of them running into problems is an awful lot lower. And it's basically doubled our expectation of the duration of control with first-line endocrine treatment. And again, we have people who continue to work, continue to go on holiday, continue to go dragon boat racing, thinking of one of my patients in particular, on this kind of treatment. And in fact, in those that we know fall into a good prognosis group anyway with bone-only metastatic disease, the median duration of control is 3 years, which is shifting our expectations, which is great news. And in HER2 positive breast cancer, I mean, this has been one of the real success stories over the last 20 years. HER2 positive breast cancer was associated with really poor prognosis until we learned that we could target this. Just like we talked about the EGFR receptor, the HER2 receptor can be overexpressed in about 1 in 5 breast cancers. So the switch isn't permanently turned on, but there's just loads of HER2 receptors on the cancer cells. So it can bind loads of the growth chemical and really drive the growth of the cancer. And Herceptin can block that. This trial is the one that really made people sit up just under 10 years ago, when we learned that if we added a second HER2 targeted drug alongside Herceptin, following alongside 6 cycles of chemotherapy, but then the chemo stops and you just carry on with the antibodies, which again tend to be really well tolerated on a day-to-day basis and allow normal life to resume, increased our expectations of overall survival by over a year. And we don't see results come along that like this very commonly in oncology. So this has really had a huge impact. Another thing, less kind of exciting in scientific journals, but now it's being prepared in a subcutaneous formula. So rather than people who are doing well on this, who may be on treatment for a couple of years or so, having to come in and have a drip for a couple of hours on our chemotherapy units, actually can have it as a subcutaneous injection. In fact, our home treat nurses can go and give them this at home or at work. So this has actually made quite a big difference recently. And again, as soon as we get a target, we like to see if we can exploit that target as much as possible. And newer drugs are coming through to help us target the HER2 receptor after our first line treatment with Herceptin and pertuzumab have stopped working. And I like these because they're clever. They use Herceptin as the kind of localizing drug, and they attach chemotherapy to it. So the Herceptin will take your chemotherapy drug essentially to your breast cancer cells, because they're the ones that are expressing all this HER2 receptor, and deliver the chemotherapy to the cells. So yeah, it is chemotherapy, but the side effects tend to be a lot less than giving standard non-kind of selective chemotherapy drugs. We've just got something new which has been approved really on the basis of very early stage trials, as it was given to a group of patients who are very heavily pre-treated, in whom most of the time, even in breast cancer, if you've given 6 previous treatments and you've got someone who's progressing, you really are worried that you're getting towards the end of the line in terms of what you can achieve. And this drug came along, had a response rate of 60%, and people were surviving on this for over a year. So this is just coming into use. So again, it's got some side effects that, I've got to say, the interstitial lung disease makes me a little nervous, but that you can see that progress continues to be made by using these targets in the cancers that we're identifying. What are the challenges here? I think the main challenge is when you do suddenly have treatments that offer far bigger advantages than just maybe a few months extra survival with chemotherapy, is that benefit harm ratio shifts. And I think there is a tendency to perhaps be offering treatment in whom the benefits are smaller, a go at these treatments. That requires a really fully informed conversation, and it never has been more true that you're hoping for something good, but you really have still got to plan for the worst. And it's made working alongside specialist palliative care teams even more important, because at the outset, whilst you may achieve something quite good in terms of disease control, there is a real risk that unfortunately people who are presenting at a very advanced stage still may unfortunately deteriorate very quickly. I think the expectations are, without us really realising, becoming that much higher, so it's harder to accept both for us and for the patients when treatment actually doesn't go as well as you hope. With HER2 positive breast cancer, we've kind of changed the natural history. We've taken a disease that actually had a median survival of just months or maybe a small number of years, and we're keeping these people alive sometimes for several years. Unfortunately, for some of these women, we're now seeing that we can keep everything under control from here downwards, and it's brain metastases that are then becoming really problematic, and that presents a real challenge to manage, both symptomatically but also because treatments don't enter the brain so well, really difficult in terms of controlling that cancer. I think as much as we've got treatments that do help without significant toxicity for many, I think there's still a real psychological burden of living with that uncertainty, not knowing when that treatment's going to fail. And I think that can sometimes be overlooked when people are coming in and they're well and they're going to work and they're doing normal things. And that's something that we have to be mindful of. And something that I'm very mindful of is that in women who have you know, 3 or 4 years ago had their diagnosis of secondary breast cancer and came to terms with it and acknowledged the uncertainty, and life's got almost back to normal, but they're still taking this tablet that even then side effects that are considered mild, the bit of hair thinning that people can get with some of these drugs like palbociclib, a little bit of loose bowel with pertuzumab, actually can become really frustrating because life is so nearly normal, but those things that have an impact can still feel really quite difficult to deal with. So in summary, I hope I haven't gotten terribly over time. Immunotherapy and targeted drugs are definitely changing the expectation of cancer treatment and making real differences to cancer care. Those advances do come with their own challenges in managing those expectations of counselling for those potentially better outcomes, but also being prepared that for some it just doesn't work as well as we would like, and preparing for time being shorter than we'd hope. Providing support for these increasing range of side effects from these different sorts of treatments, and also acknowledging the psychological burden of living with an uncertain prognosis even when cancer treatment is going well.